And with that, we come over to...
Would you like to say which corneal lens that they have to buy? Would you like to say some corneal lenses which they can buy and use it?
Sir, any two mirror,
Any
no,
two mirror.
no conflict of interest.
Okay, so just for the practical reasons, I will just tell you, either you buy a single mirror or a two mirror, which we have to use a coupling solution if you really want to see the angle properly. You have the gonioscopes where you don't have to really use the gel, but that is for practical reasons. If you quickly want to see the angle, you can do it. But ideal conditions for a learner, it is better to use the coupling solution and use the corneal lenses. But if you really want to do a documentation, videographs, and uploading your YouTube channels, then you have to buy the corneal lenses, which is used for SLT corneal lenses. That gives you a wide angle view, and also that kind of a view you will never get it in your regular corneal lenses. Only thing is it is a little expensive, but if you really like to document it, save a lot of collections, then you should use that. So thank you so much. You can just keep talking about that. So next 10-15 minutes, I'm going to call at least one or two PGs for this. It's an interactive session. So visual fields, doing a visual fields in glaucoma becomes mandatory. There is no reason you can say that I'm not going to do the visual fields in this, unless otherwise the patient has a poor vision, there's a media opacities, the patient has a lot of disabilities where he cannot really do the visual fields. Only those patients you have the allowance not to do the visual fields. Otherwise, every patient needs a visual fields in glaucoma for us to stage the disease. Okay, still you're not getting it?
So till then, we'll just revise that what all we have learned so far. So optic disc evaluation, how will you follow that? From where will you start the optic disc evaluation? That was the first lecture, right? We had. Any of you? It's simple, no? You do it in your clinics every day.
I think I'm ready, Shweta. I think you just come back. Okay. All right. So the visual fields becomes mandatory for two reasons. One is for us to understand what is the stage of the disease. Second thing, it is important for us to say whether the patient has a stable disease or is it a progressive disease, for two reasons. We have widely used is the Humphreys visual field machine, and we have the Octopus as well. So I'm just going to touch upon both the instruments here because it is been there for a practice for a very, very long time. So let's see. But you need to have the workflow or interpretation as a proper flow. This is how you should read the visual fields. First is to look at the patient factors like name, age, and whatever other things. Then you have the examination parameters. The second part is it the visual fields? So just go with my adapter.
Clinic. So please, that's my request, that please pay attention to each and every word which is being spoken. Later on, we'll have an open house discussion also.
So it is connected to your system.
So any idea, like you have finished your residentship or you are like first year, second years, what? First row.
Okay.
What? First year, second year, third year, second years. So how many like visual fields, you know any idea about visual fields you have? How many types of visual fields are there? Two, right. Come up with that. Two. What is that? Octopus and the other one, sir just said no. Octopus and the other one? Humphreys. Have you used Humphreys? Okay. So before we start any visual field analysis, as sir had just started in his discussion, that pointing out the patient's age, the date of examination, the pupillary dimension, and also I'm sure that sir is going to cover all these points, but just briefing you with that without the presentation right now. So these are very important points. Why the date of birth is really important in visual field? Because the machine has got a data setup, and with which it compares your patient's data, and then it gives that how much points have been depressed. Understood? So that is why, so okay, we are back with the presentation.
I'm really sorry about that. So what you need is, you need to see, is it a trustworthy visual fields that you are reading, or you just want to discard it? Then how much the patient has the visual field loss. In general, as a local defect, a general defect, then you have to see how much is the local defect. Then again you see if the local defect is there, is it really a glaucomatous defect or is it something else, a neurological or local defect? Then if it is only the glaucoma defect, then you see whether it is structurally correlating with the defect which is there. You look at the polar graph. The polar and the cluster graphs are available only in the octopus visual fields. Then of course you look at the severity of the disease, how much it is there. So this is the typical Humphrey visual fields, but this is the octopus machine. But the printout, you can get it as a Humphrey printout. That is one advantage with the octopus machine. I don't have any financials with them. So the first, there are 8 zones. I have divided as 8 zones in octopus as well as in the Humphreys. The zone 1 is the general information. Always look at the patient's date of birth is whether correctly mentioned or not. Then you see that whether age is being mentioned properly or not. Sometimes the time of the test also matters a lot, because the afternoons when you do the test may not be really good. The patient may be feeling very sleepy. Then you have the other parameters like what is the fixation target. Some patients may have a poor fixation, so you may have to go for a parafoveal fixation. Then you have the fixation monitor that is available only for the Humphreys. Octopus, it is not really required. Then you have the stimulus size, that is either 3 or 5. You go with 5 only in case of where the vision is poor. Then the background is always fixed. Then you have the strategy. In octopus, we use a G dynamic. In Humphreys, we use a CETA fast, or CETA standard is a normally used one. Sometimes they use a CETA standard as well. The pupillary diameter becomes very extremely important. If it is less than 3 and more than 6, both becomes a difficult thing to assess the visual fields. Then you have to always mention the visual acuity as 6.6, 6.12 or whatever the vision. Why it is important is when you have a 6.6 vision, and if your foveal threshold shows only 10 decibels, then it means there is something wrong is going on. Then you have how much is the refractive error the patient has. This is very important. Every part has its own importance. The second zone is the reliability indices. All of you know what is the fixation losses. Then you will have to see that. Then you have the numerical, the threshold values. Whatever the sensitivity is measured, that is calculated in the numerical data, that is shown as a grayscale. That is the typical of Humphreys. I will show you the difference. Then you have the total deviation, then you have the pattern deviation. Total deviation is inclusive of all, diffuse as well as the local defect. Pattern standard deviation is only the localized defect which is relating to glaucoma. The same thing is shown in the probability plots varying from 5% to 0.5%, and you have the global indices which tells us about how the severity is. Only based on this we are going to fix up the target pressures once everything is okay. So this is a typical octopus printout. We have a 8-in-1 or 9-in-1 printouts in the octopus. Whether you have a 300, 600 or 900, any of the machines, you will have this. So I'll show you the differences in this. The first one is the Humphreys, second one is the Octopus. The threshold values are same as values in the Octopus. The grayscale in the Humphreys is little different from the grayscale of Octopus. The grayscale of Octopus is basically taken from the total deviation plot of something similar to the Humphreys. So it is precisely what it means for the age-corrected values. Then you have the total deviation plots of Humphrey, which is comparison to the comparison of the Octopus. Then you have the pattern standard deviation as called as a corrected comparisons. Then you have the probability plots called as a probabilities, directly called as a probabilities. In this, it is called as a total deviation probability. Then you have the PSD probability. So it is called as a probabilities and corrected probabilities. Then you have the mean deviation in Humphreys, that is called as a mean defect. Then you have the PSD, that is called as a SLV, that is a square root of loss variance. We can discuss this a little later. And you have the glaucoma hemifield test. In this, it is little different, that is coming under the defect curve, that is called as a Baby's curve. Then you have the visual field index, but that is again different. Then you have the fixation losses, but what is this fixation losses is little different in the Octopus is, it gives us out of 8 questions asked, the patient has answered 1 as a wrong. So it comes as a percentage values. But in Humphreys, it comes directly as a percentage values. Then the fixation losses and gaze tracker, both will not be available in the Octopus because the machine automatically adjusts. The moment the patient takes out the head, the Octopus will not do the test anymore. So that is very typical of Octopus test. So this is the Baby's curve, which gives you the details about how much is the local defect and how much is the diffuse loss in the patient. So I'll just give you an example of 1 or 2 patients here. So anybody wants to volunteer here? Any one of you? Can come, I will not say anything. If any of you want to volunteer. Dr. Ashwati wants to, yeah, please, if anyone can. If you know about the Octopus, you can read the Octopus. If you know only the Humphreys, I'm giving you the pattern of Humphreys. This is an interactive session. There is no point in me just keep talking about all the time. So anyone?
One of you could volunteer and come here. This is not your real YYOC.
Just make some mistakes, whatever. I'm really happy about that. Just read only the zone 1. Any one of you can read. Is there anything wrong in the zone 1? So always go with only a methodical flow. Many of us as an Indian, we never do that. We just go directly, only see the grayscale, and we see the PSD values and say, okay, this is mild disease, moderate disease, or severe disease. Quickly, any one of you want to say about the zone 1?
We'll start here. Anything you want to say, like
anything?
Yeah.
Everything correct or anything wrong in that? Just a quick thing. I hope you can see that.
It's the visual field analysis of a 55-year-old patient.
Wonderful, yeah.
With the pupillary diameter of 4.2 millimeters.
That is exactly I was telling. Never jump from one end to the other end. Always go with the methodical order. Age is 55 years.
Taken on 25th.
The timing of the day is reasonably okay. Then you come to the fixation, whether it is a central point of fixation or is it a parafoveal.
It's central point of
central
fixation.
Point of fixation. Then you have the stimulus is 3. 3 is fair enough. Then you have the strategy, but in this is a G dynamic, that is in the Octopus. But usually what else you have? You have, what is the Humphreys pattern? It is a Zeta standard, which is comparison to the G dynamic. Okay, then is the pupillary diameter okay?
Yes, sir.
So what is the normal range you wish to have?
3 to 6, between 3
in between 3 to 6 is fair enough, that is okay. Then visual acuity is not mentioned. So is it right thing for you to read this chart or not? It is okay because you will have the data somewhere else.
Okay,
but you have to understand, once you have the visual acuity 6.6, if the foveal threshold values are very less, then it is important. There is something wrong is going on, okay? Then you have the glass powers have been mentioned properly. Okay, so that is zone 1. Zone 2, anybody wants to comment? quick thing.
Yes, sir. Zone 2,
Wonderful.
false positive error rate of 14%,
Yeah.
false negative error rate of 0%.
Okay. I just want to
Fixation
show you that
losses,
same thing.
there are no fixation losses noted.
Yeah. I just want you to see the same thing in the zone 1 and 2 in the bottom. This is the octopus. If you really see that, that is called as a catch trial. I thought you don't have a power. Your father has put in a good lens for you.
Yes, sir. One out of 7.
Yeah. So that is coming as a 14%. And 8, 0 and 8. So that is 0%. So that is called as a catch trials in the octopus. It is not that difficult. So I'll just, go back to this one. The zone 3. So even if you read only one chart, I'm okay because the rest of it is the same. 3 and 4. So what is 3?
Total deviation.
That is a values, threshold values. Whatever the patient sees, he presses the button. So that is the threshold values. Whatever the sensitivity, retinal sensitivity in each location is called as the threshold values. Okay, that is the threshold values. And on the side, the 4 is the grayscale. So this is not age matched. It is just whatever the patient presses, it comes. Okay. Then you have anybody else to volunteer for the zone 5? Quick. Zone 5. So zone 5 is the total deviation, but I want you to see this. Zone 5 is, and zone 6 you see some minus values in this. Okay, that is how much it is deviated from the normals. But in the octopus, if you see, it will not show as any minus values. Octopus, the deviations will be shown as only in the plus values. And if it is less than 5 decibel loss, it will not show any values. It will show only a plus. There is some change, but the values are less than 5 decibels. So that is what it indicates. Then you have the probabilities here. Is there any defect which you see here in the probability score? There is no change. And in the zone 8, the mean defect is only 1.4 and the PSD is 1.9, which is fine. So, but we should never relate this to only looking at this and you can say normal, but you have to always correlate with the fundus photograph. So this fundus photo shows any defect in this? There's absolutely no defect. But this patient came out as a toxic optic neuropathy by looking at only in the OCT. Okay, that is called as a temple sign that we can discuss it later. So that is why I'm saying having done only one test, coming to some conclusion is not good enough. So I'll just go through another one more. You can see there, so with all the parameters, I'll just go through a very quickly one. You can see the scotoma in the central 10 degrees area. Can you see that? Yes, scotoma in the probability plot you can see in the central 10 degrees. So what is that you see is a small defect in the inferior RNFL area. I want you to just understand this and then I'll show you this in the black and white picture. Again, it picks up beautifully. So what is the importance is I want you to see this photograph again. Carefully you see the RNFL defect, which is very close to the central papillomacular bundle. Any defect which is close to the central papillomacular bundle with the normal IOP values, it is called as a NTG pattern. So once you see this central defect, which is close to the macula, that is called as a NTG pattern. So you can read this chart very carefully one by one, then you can really understand, is it you are discussing the POAG, PACG, neurological or NTG, all these things can be really picked up. So we can discuss more and more as I think the time is just running out. We can discuss more after some time once we have the discussion time. Thank you so much.
Thank you, sir, indeed, for beautifully eliciting out the important features in field